Good afternoon, everyone. This is Debbie Thompson, President of Strategy Solutions, and I'm delighted to have the opportunity to be here with you today to talk a little bit about how to take your community health needs assessments to the next level and to include information about the social determinants of health. This is a topic that I'm very passionate about and have grown to really be mindful of as we do any community health needs assessment work for hospitals or community organizations. So what are we going to do today in about our half hour of content? We're going to talk a little bit about what I call the evolution of thinking within hospitals and health systems or just community agencies as they gain experience in conducting community health needs assessment. I have seen an evolution in thinking over time, and the more experience people have and the more experience there is across the country in learning more about needs assessments, there's an evolution that we're seeing, so we're going to talk about that. We're going to share information about how to augment your community health needs assessment data related to the social determinants of health and give you some concrete examples of information to put in your CHNA, and hopefully give you some tips and tricks on how to create an action plan for you to include more information on the social determinants of health to enhance your own community health needs assessment. So I'm going to ask, if you're on your computer, I have a couple of polling questions on here. So if you could go, I think there's an option in your on
the conference has been muted.
That you could actually answer each of these questions. So which of the following best describes you? Are you a hospital president or a hospital or a health system president, a president or a market leader, or some director level? I would pick that option. Or if you're a community benefit team leader, pick that option. Or if you're a program leader in an organization, pick that option. I'll wait just a minute for folks to respond. Okay, we have community benefit leaders and some other roles in organizations with us today. Welcome. A little bit about Strategy Solutions for those of you who may not be real familiar with us. The mission of our company is to create healthy communities, and we work with a variety of different sectors and have over the last 20 years, both community government and social service sector, including hospitals, health systems, public health departments. We've also done a number of projects for private sector companies as well. So we have sort of this interesting view of how different systems work in a community and how information can be gathered kind of from those other sectors. And as we thought about how do we build more social determinant of health thinking into our work, going back to and sort of leaning on some of that cross-sector involvement has been very helpful for us as an organization. And as we do any type of planning or evaluation with organizations that we work with, we're always asking these 5 questions. Where are we now? Where do we want to be? How will we get there? Who's going to do what? And then how are we doing? That's the way we look at the whole CHNA process, how we look at implementation strategies and evaluation. And the approach that we use when we work with clients is what we call a do, teach, coach model, that we try to educate our clients and the folks that we're working with to really do things on their own, even without our support moving forward. So that's pretty much a hallmark of who we are as an organization. I also want to mention that, you know, if we're in a hospital or a health system and we're doing community health needs assessments, you know, the letter of the law, of course, is that we conduct these needs assessments every 3 years. We have to identify chronic disease conditions and community health needs. We have to have input from a whole variety of different stakeholders, and we have to evaluate the outcomes and impact. And we believe that that should be done annually with the 990 submission, even though that's kind of a gray area for some folks. The spirit of the law is that the CHNA, in our view, is not an unfunded mandate. It's a tool to support population-based planning and healthcare delivery systems focused on the triple aim or the quadruple aim: prevention, improved quality, lower cost, improved health status. That's really what we want to see, the impact to create a healthier community. Now, this slide actually explains that evolution that we've seen over the years, that as community health needs assessment processes continue and more people get more experience in them and start doing them more often, you sort of move up this sort of hierarchy. I made the pyramid to look like Maslow's hierarchy of needs because there really is this self-actualization process going on that we've seen happening across the country. Because back in 2012, recently after the IRS passed the draft guidelines for how to do a community health needs assessment, a lot of hospitals and health systems were doing them simply because it was required. It was a compliance-only exercise. People wanted to look for the most expeditious way to get it done, and they weren't really thinking about so much, what it meant and what they were trying to do with it and how it fit into their business strategy. It was just like one task that needed to be assigned to somebody to do. And what we've seen is that as time goes on and people get more educated about what they're doing and why, that they start moving up this ladder, so to speak, that the focus then will move to prevention, and in some cases just what I'll call hospital-focused community benefit. The implementation strategy is just the things that the hospital is going to do to improve disease indicators or to address cancers or diabetes or COPD, but they're very clinically focused around disease entities and prevention. Of course, there's a preventative aspect, but there's not a lot of talk about the social determinants of health. And as you move up the ladder more and people get more experience, now we start to see programmatic interventions to improve health status of a population. We want to improve the health of all of our diabetes patients or even people with prediabetes. And then as time goes on, we start to realize, well, gee, our organization alone is never going to solve the community health equation. We really need to get collaborators and others involved in this. And now we start talking about, well, how do we impact the health status of the broader community? And we start to do things that speak to and start to address the social determinants of health or collective impact. Now we're trying to work together as a community and with various entities in the community to solve these issues. It's not just us, and we're also not trying to just address the needs of people that show up. We're trying to address the underlying root causes. And that evolution then happens, and you start to see hospitals now evolving into what are called anchor strategies, where the hospital is making a significant investment in the community, but it's also receiving a benefit back from that investment, but being a good neighbor. And some hospitals and health systems and collaboratives then start working on perhaps influencing public policy to create healthier communities and really get involved with the local planning commissions, for example, and start to create more walkable communities, or what are called active transportation plans, where we deliberately design the community to have more bike paths and more walking and riding trails so that people actually have healthier lifestyles, because there's lots of data that suggests that if people live in a community that have sidewalks, they actually walk more. So all of that data takes us now down to more thinking related to public policy. So I'm curious, of the people who are on the call today, which of the following best describes your organization's health improvement efforts? Is your organization focused on just compliance only? Is there prevention or a hospital focus? Are you working on those programmatic interventions to make a difference in the population? Are there collaborative interventions happening in the community? Are you working to collaborate across sectors or working to influence public policy? Okay, here's our result. We have some collaboration going on with folks and some programmatic efforts, but not anyone on, up on the, what I'll call the influencing public policy place. And I'm glad to see that we don't have anyone on the compliance only. We're seeing less and less of that as time goes on, which is really great to see. Now, to what extent does your current community health needs assessment include the social determinants of health? Are you putting a lot of emphasis on the social determinants of health now to a large extent? If you're doing it to some degree or not at all? I'm going too fast. There we go. Most of the folks say to some degree, and some people are doing it to a large extent, which is really great. Now, here's the strategies that we suggest how to augment your community health needs assessment to really make it more focused on the social determinants of health. I'm going to be talking about 6 strategies over the next few minutes that are easy things to help you augment your CHNA, and many of you may already be doing them, but we've found them to be quite effective. So these are the 6. Expand your data collection. We'll even give you the list of indicators. Conduct what I call targeted outreach. Go after certain people and try to get their input, even if you have to go to them. Synthesize the data and tell the story. And I'll talk about that, put different pieces of data together to talk about what the implications are. Number 4, ask people to respond to the data itself. Number 5 is include hospital utilization data, and I'll talk about some specifics that we think are good to put in a needs assessment. And then the last one is to use your community resource list to identify possible collaborators if you're not already doing that. So here's the first one. Expand your secondary data collection to include what we call healthy community indicators. We started down this path in looking at the social determinants of health a couple of years ago. So this presentation to some degree is as much a case study of a journey that we've been on the last few years with one of our clients, as much as it is kind of a how-to guide of some of the lessons that we've learned. And here's the list from the Kaiser Family Foundation of the social determinants of health. They include things like economic stability, neighborhood and physical environment, education, food, community and social context, as well as the healthcare system. And I mentioned a couple of years ago, we did a really, probably the most comprehensive needs assessment, or one of them that we've done ever, for the Mat-Su Health Foundation in the Mat-Su Valley of Alaska. Even though it's a reasonably rural area, it's the geography, the size of the state of West Virginia, but there's only 100,000 people who live there. Now, that doesn't sound like a lot of people for those of you who might be from a metropolitan area, but the population has grown about 25% in the last 7 years, and it's expected to continue to grow. And in a rural area that doesn't have a whole lot of infrastructure, that has its own set of challenges. And they were very interested in learning about the social determinants of health. So part of their project, we did an extensive literature review on all of the indicators that were part of the social determinants of health, but we expanded it to also include some community context and social things that were going on, as well as the neighborhood and the physical environment, more from a sustainable communities perspective. If you're familiar with any of the work that's coming out of the American Planning Association related to best practices in land use planning and comprehensive planning for municipalities. So we took some of our knowledge from that and really started talking about and including information on the civic environment and community safety and economic security and education and employment and housing and environmental quality and neighborhood and a neighborhood level analysis, because depending on where you live, it really makes a difference. And looking at the data in terms of the pockets where either poverty is higher or certain conditions are higher, it really tells you a different story perhaps than if you look at the data only in the aggregate. It's very insightful that way. And we added into it what we call the list of healthy community indicators, early childhood development, child care rates, waiting lists for child care subsidies. A lot of communities in most counties across the country will often have child care on a sliding fee scale because there are subsidies available to low-income people to help augment that child care cost. Well, the number of people who are on a waiting list for early care and education is actually an indicator that is worth looking at in communities. And you can get some of that data if you know where to ask for it. Education, jobs, training, and jobs, health and human service data, food system data, parks and natural resources, the built and natural environment. How many parks do you have? How many parks are there per capita? How far is it to the park? How far do people have to travel to get to a park? A lot of this information is available in your communities, in your community planning departments. If you live in a city or in a county or a municipal area, those municipal areas will have often maps of a lot of this information. We don't think that many people don't know there's a county comprehensive plan that often has a housing analysis in it. It'll have a transportation analysis. It'll have an economic analysis. And it's really great information about what's going on in your community that could be part of your needs assessment. We were working on a workforce study this past summer and brought up the fact that the federal government, as they do transportation planning, each transportation planning district, which depending on where you live is called either a metropolitan planning organization or a rural planning organization, they actually plan all the highway improvements in your local municipal area. As part of the highway planning, there is plans for public transit, for what's called shared ridership, and there's usually also a human services transportation plan, which looks at the barriers that disadvantaged populations, whether they have a disability or they're low income or they're a particular population, those plans have data in them about the challenges and barriers that people have for transportation, as well as what the transportation system is trying to do to improve that process. So if you know about what's going on in these other sectors, there's information there that you can use in your community health needs assessment, and much of it is available if you go looking for it. Community and economic development data, information about job creation and how far people travel to work. A lot of times you don't think about how far people travel to work, but if you live in an area where people travel, a large percentage of the people travel more than 45 minutes to work, you have a population that doesn't necessarily seek health care because they can't get to a doctor during the day or business hours or on weekends, if there's not hours for that. Neighborhood development work is really important in looking at the fabric of the neighborhood and breaking down your geographic territory into a neighborhood level or a community level. And looking at the differences in the community makes a big difference in what the perceived needs are in that particular area. Like you may have pockets where people are really worried about safety, or where safety is a legitimate concern if you look at the crime rates. And if you map the crime rates in a particular geographic area. Housing is becoming more and more important, and we hear a lot about the role of housing in well-being for individual people. Most counties across the country have housing studies being done and have efforts underway to eliminate homelessness or to address homelessness. They have a lot of good data on the topic that could be included. Community and public safety, your emergency management system, and accidents rates and information about how people access the system. Talking to police officers and getting some data from the system often can tell you about what's happening with certain populations. And then the law and justice system. Many of our court systems today are doing things called therapeutic court or drug court for those people who have drug problems. We talk about the opioid epidemic, and we look at death rates, but we don't often go and collect that information from the justice system, where we have people in the drug court system, and how many people is that, and what percentage of the population is that, and marry that with the other data we have on death rates and incidence rates. It tells us a different story about what's going on in the community. And as I mentioned, all the listeners to this webinar today will get a copy of our indicator list, and Kathy and I are happy to answer any questions that you have about where you might get these indicators if you don't know how to find them. We're happy to be a resource for you there. The second strategy is to conduct targeted outreach to underserved neighborhoods and or specific underrepresented populations. And here's where there's a lot of different types of interventions or different types of people at different levels that you might want to involve. At the society level, at the community and policy level, at the individual and family level. And that targeted outreach should be to people in the know, as well as potential collaborators and folks that work with or represent some underserved populations. So, for example, you might want to talk to people who are involved in trying to develop pro-equity policies, either in your community or in your state. You might want to talk to people who are doing advocacy or who are trying to address things like structural racism or privilege. Those folks will give you an interesting perspective. We often do what we call captive audience focus groups and outreach, where we recommend going out to a particular group of people that are already assembled who are going to be at a particular place. Like, for example, we have ridden city buses in cities to conduct intercept surveys of residents riding buses to talk about transportation issues and to get their insight into how transportation might be improved to meet their needs. We've gone to county fairs and intercepted people who are there, particularly looking for farmers, because farmers have particular environmental concerns related to things like pesticides that if you're in a rural community, that might be a health issue, and it doesn't really come to the fore. So that's a way of getting information. You might also, we've gone to food pantries, and we've sat with people as they're waiting for the food pantry to open to talk to them about what issues do they have, what do they need, how do they access the healthcare system, and what kind of things would be helpful for them. We've talked to people at community days where there's a specific population of people, say within a Hispanic group or with New Americans, so we can find out what their issues are in particular. So and a place to look, and we don't often think about this. Well, who should we get as a stakeholder? Look at your community resource list that you have to put together as part of the needs assessment process, and think about all of the agencies that may be on that list that serve different people. Those are the folks that serve folks in need. Talk to them about, can they convene a group? Can they give access to a group? Can you get information from somebody who works there that works with a particular population, but target very specifically particular neighborhoods or particular places? And we've also, in addition to trying to get representativeness in different stakeholder groups, we try to get representativeness in different geographies, because we find that it gives us a more complete look at the needs of a whole particular region. Our third strategy is, don't just report the data in charts and graphs. We encourage you to synthesize your data by combining the primary and secondary data to tell the story of what is happening in your community, or in a particular subset of your community. And the next couple of slides actually these are excerpts, you can't read them, but I'm going to encourage you to go to Google the Matsu Health Foundation Community Health Needs Assessment. And Kathy, when she sends out the information for this webinar, she'll send you the slides, she'll send you the list of indicators. She'll also send you the link to get to their needs assessment and to their supplemental data resource. Because even though this is a page out of their report that was really designed around, health is where we live, learn, work, and play, and how all those different characteristics impact our health. And we actually, as we did that needs assessment, we actually looked at what life was like in each of the sub-regions of their broader community, and looked at how all of the demographics and social indicators, social determinants of health, as well as all of the typical, what I'll call the typical health indicators of disease rates, impacted the people there, and what the results were in terms of various factors that impact health. And I encourage you to take a look at how we put that together, because what we did was all of the data that we showed, we didn't just show what I'll call raw data. Everything was cross-tabulated, or even cross-tabulated a couple of different ways. So we could look at age and location, or gender and location, so that we're really telling the story of what's going on in small pockets of the community. And this is again, it's hard to read, but you can look at it in the source document. One of the things that we looked at very specifically for this particular needs assessment was, what was the experience of the LGBTQ community? Alaska had some of the questions about gender and sexuality in their behavioral risk factor survey. So we could really talk about and see some of the disparities within different populations, because they had pretty robust data that could be analyzed, and we could look at it over time and with a pretty robust data set. So we looked at healthcare satisfaction. We also looked at things like how early care and education impacts health, as I spoke about earlier, and how helping kids, we look at graduation rates sometimes in terms of education. We might look at literacy rates, but we also ought to be looking at what percentage of the population is ready for kindergarten, and what's the third grade reading level, or kids age appropriate at third grade and fifth grade. And all of that data is available from our public education systems. So we should be really thinking about those things, not just look at the graduation rate at the end. We should be looking at how kids kind of flow through the system. And data is available on transition age population for kids with disabilities, and how many kids are there of which disability. Our public education system has all of that data, and really speaks to how well those kids are being transitioned into adulthood and into employment. Again, all part of the community needs assessment. And this is one of my favorite infographics. how transportation impacts health. Many communities actually calculate a transit access score where they look at, comparatively speaking, how, if you live in one place, how easy is it for you to access public transportation versus if you live in another place. So this is just a nice way of saying, if we live in some areas, we have good access to transportation, and if we live in other areas, it's worse. And you can target right away what those areas are that show us that we have challenges. So these are just some examples of how various pieces of information are put together. The report I mentioned has lots of others, but we synthesize the data is the message there. Don't just report the raw data. Look at what it means and tell a story from it. Now, we also have found over the years and find that if you ask people to respond to the data itself, we're actually going to get different and richer conversations with people if we're doing focus groups or stakeholder interviews. And this is interesting because we actually have taken some of the disease incidence rates and some of the data, and we've shown it to people before a focus group. And then we talk to them about, not only what they think the priorities are, because we'll ask them, kind of off the top of their head before we show the data, what do you think some of the community needs are and priorities, but we'll show them the data on various indicators, and then we'll hear other new and different things. So people have perceptions based on what they believe they know and what they do know, but if you inform them a little bit about information that they may not be aware of, you get a completely different look and some insights into people's feelings about the data and the situation itself. And it also gets people more interested in becoming more engaged and involved, not only in their own health care, but in the community and helping to link other people as well. The fifth strategy is to connect the dots within your hospital and health system. What do I mean by that? It's, as I talked about before, the community health needs assessment is not just a standalone exercise that may get connected to some degree to community benefit and prevention activities. Hospitals and health systems, or any organization for that matter that is involved in the community space doing anything to promote community health improvement, ought to be thinking about how those activities tie with their own services, their own products, and how does it tie, if you are in a hospital or health system, how does that tie with your readmission and your post-acute continuum of care strategies? Because in some places, those things are all distinct, separate activities. But you really ought to be pulling them together and putting them together to be thinking about, well, how does one relate to the other, and how do we really make an impact on the things that are going to improve people's health status and well-being, as well as keep them out of the hospital, and start to really think broadly about how to pull that all together. We're in the process this week of evaluating. We've been working with a group of hospitals and health systems for almost 30 months and doing needs assessment and helping them with their outcomes measurement and evaluation processes and helping them learn them. And, we're asking them to, share with us some of their, key learnings and aha moments. And it's like, well, the stuff seems all overwhelming at the beginning, but once we get it, okay, we can connect it to our strategy, our business strategy, and now it all makes sense. Now we feel like our whole organization is working together to achieve the outcomes that we want, and we see where the readmission work fits in with our service line development and how that all ties together in one nice little cohesive series of efforts to make a difference in the community, and that's what we want to see. So we encourage you to tie those efforts together. And specifically, look at some utilization information from the hospitals. If you have access to utilization information for the community, like, for example, we're located in Pennsylvania, so we have the Pennsylvania Healthcare Cost Containment Council. So nonprofits and other organizations can get access to that actual data. So we can actually do a report that shows not just the utilization from this one hospital. We could see all the hospitals, all the patients that went to any hospital in a particular geography. We can look at incidence rates of, hospitalization. We can look at, what kind of people have to go for care outside of their local area and for what kind of conditions. We can look at a lot of different things, which is really helpful. These are the must-haves in my view. First is look at ambulatory care sensitive conditions in the emergency department and inpatient. And we will, as part of your packet, include that information of it's actually ICD-10 codes today. The original publication came from ICD-9 codes years ago, and DRGs for inpatients. We have a list of those that are considered ambulatory care sensitive conditions. We also have a list of the ICD-9s, which would be, or 10s now, we have it crosswalked. There will be mental health conditions in the ED and inpatient. And, I've been encouraging folks lately to really look at, in their high utilizer population, separate the folks that have chronic diseases only from those that have some type of mental health diagnosis somewhere on their medical record. Because the folks that have a mental health diagnosis in addition to a chronic disease are the ones that tend to have higher utilization, and to look at those two populations differently because their needs are actually different. And I don't see a lot of hospitals doing that in terms of their implementation strategies. So that's just another suggestion. We also suggest you look at high utilizer numbers, conditions, and costs, and again, try to differentiate those that have behavioral health related conditions, because it will give you insight into what's going on with your patient population that you wouldn't otherwise have. And we think that the utilization information tells you a lot about the health of your community and what's going on with the patients in your area. And then our last strategy is to use your list of community resources required by the IRS as a pool of potential collaborators to address the social determinants. These people, these are the resources that are available to folks in your community to address these concerns. There's sort of a natural thinking, maybe, that these are the people that you ought to be working with. And I don't see everybody making that connection. And that type of collaboration can often make a huge difference, especially if you want to do things like address food insecurity or help people, get clothing or shelter or others of what I'll call the community basics that people need just to have a decent life, let alone work on their health status or improve their health status. So in summary, if you want to augment your community health needs assessment to address the social determinants, this is how you do it. These 6 strategies will help give you a better product with more interesting stories and more insight into what's really going on in your community. Expand your data collection, include those indicators we recommend. Conduct targeted outreach, both at the what I'll call the focus group or the population level as well as the stakeholder level. Synthesize your data and tell the story from it. Don't just report charts and graphs. Ask people to respond to the data itself. You'll get much better feedback from them. Include hospital utilization data because it'll tell you a story and tell you information about one component of your population. And finally, use your community resource list to help identify collaborators. Using these 6 strategies make a big difference, we find, in the robustness of the report that you'll get at the end of your needs assessment. So with that, our prepared information has come to an end, and I will ask, does anyone who's on the call have any questions? Let me unmute everybody so somebody can
The conference has been muted.
Anyone have any questions? I want to unmute.
The conference has been unmuted.
questions anyone has? I see one question via the chat feature, and that is, what was the thinking that caused you to develop this set of indicators? That's an interesting story because when we first started working on the MATSU Community Health Needs Assessment, we actually responded to an RFP asking us to do a social equity analysis. And I actually spent more time researching best practices in social equity than I did writing that proposal. And what we found, in addition to a lot of rich information on the indicators, the state of Connecticut actually has a very cool technique that they use to do social equity analysis that does like it overlays maps one on top of each other of different indicators and looks at how different elements of the social determinants of health actually work together. And we actually proposed to do that as part of our work, and ended up not doing it because a lot of the data wasn't available at the neighborhood level in Alaska. So we did what I'll call a more qualitative approach to cross-tabbing the different pieces of data and told the story that way because we couldn't do it based on what I'll call a real social equity analysis would prescribe. Any other questions? I am then going to turn off the recording, and if